This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 607, recorded on April 28th, 2020. I'm Vincent Racaniello, and you're listening to TWiV, the podcast all about viruses. Joining me today from Austin, Texas, Rich Condit.
Hi there, Vincent. How you doing today?
Very well.
We got, I don't even know. I haven't looked. I think it's probably mid-70s and overcast, and it's the morning, so I'm just basically getting going with my coffee here.
Looks like it's sunny out here. A little chilly. I think it gets pretty cold during the night still. Our guest today is from the Department of Environmental Health Sciences at the Mailman School of Public Health, which is part of Columbia University Medical Center, coming back for his second time. Jeff Shaman, welcome back.
Thanks for having me, Vincent.
You were last here in September 2014 during the Ebola virus outbreak.
That's not a good track record if I'm appearing in response to catastrophes.
I don't know. Do you feel that that's when people contact you most, when there's an outbreak?
I seem to be a little bit more popular at those times. That is true.
Well, we can try and get you back on off years. You know, that would be actually nice because you are right across the street from me.
Exactly, yeah.
And we certainly come up against epidemiological issues all the time.
Oh, all the time. And people tell us you should get an epidemiologist on. So now we have one and we can pick your brain. You must be at home, right, Jeff?
Absolutely, yeah. I'm just sitting in my apartment in New York City.
Great.
Trying not to go stir crazy, keeping up with the work and trying not to be overwhelmed by lots of Zoom calls and trying to keep the kids sane as well, since they're doing all their virtual schooling and such.
Yeah, I was just talking to Rich that pretty much every hour of my day is accounted for between teaching and podcasting and talking to people. I'm sure it's the same with you, right?
Oh, absolutely. I don't think I've never been this busy. It's really remarkable.
I'm actually looking forward to going back to normal. All right, so let's. We have a number of epidemiological questions we wanted to discuss with you, but maybe first you could give us an overview of the current situation with SARS-CoV-2 globally. From our uninitiated eyes, it looks like in many countries the number of infections per day is decreasing. What's your take on it?
I think we're certainly seeing that in places where, frankly, you might trust the records that are being provided to the WHO more. Mm-hmm. So certainly in areas such as Europe, in Spain, and France, and Germany, and Italy, and the UK, there's indications that they're on the downslope. It seems to be a gradual downslope, not as precipitous as what they were able to accomplish in Korea. But they do seem to be on a downward trajectory. Belgium is a little different, maybe a little bit. In the Netherlands also, maybe we have to watch it for another week or so. And the Scandinavian countries as well, it's a bit of a hodgepodge. Sweden has imposed very different set of policies than Denmark and Norway. So that's an interesting place to look at to see how they diverge in terms of their trajectories going forward. In the United States, we have been flattening a bit for the last week or two at this point. So what we would like to see is sort of a downward trajectory. But of course, we have a real patchwork of responses that are being directed at the state level rather than at the federal level. And the consequence of that is that we're going to see this piecemeal approach to controlling it, where social distancing is going to be abandoned first in some places. It already has in Georgia, and Texas is coming up, and others are rescinding their shelter-in-place or stay-at-home orders. So we're going to have some variable responses that we're really going to have to monitor right now. It's going to be a little difficult because we don't have the testing capacity. But more broadly, Brazil is still on the rise right now. What happens in South America is something that we have to keep an eye on. I don't, frankly, trust the data out of India. India has been the country I worry about the most because they have such a large population. It's a very densely populated country. They have obviously a very large and thriving middle class, but they also have a lot of people who are still in the cycle of poverty, for whom access to medical care and cataloging of actual cases and documentation of that may be very difficult. So they've been under a lockdown now for about a month, but I really wonder what the extent of the virus truly is in India. And I think there are lots of other countries where we're not going to be really receiving accurate information. Much of the developing world may not have the capacity to test. They may not have the capacity to record and document and provide that information to global authorities. And they also may not have the availability of the healthcare services or their utilization that will actually allow them to document a large enough portion of their population to really know what's going on. And see something that would be provided in comparable numbers to what we see in places such as Europe and North America and parts of East Asia. So I think it's a very confusing situation because there is such a diversity of testing and reporting practices that are taking place, not just state to state in our own country, but even more so country to country around the world. And that makes it a little bit complicated to know what's going on. I do think that we're going to be seeing soon exponential growth in places where we might not be able to observe it well. Like I say, we'll be able to see it. I'm not sure we'll be able to see it. I'm just really concerned that it may be going on or will go on in the near term, and we won't be able to document it as well as we have in, say, Europe or the United States or China and Korea.
What's going on in China? I mean, I understand they still have cases every day, right?
They do. That's what they report. And honestly, I can only speculate as to what might be going on. Frankly, you do hear statements that say that they're not reporting or being as forthcoming about what they're currently experiencing as they could be or should be. But the validity of those comments, I really can't speak to. I just don't know. It's not my purview. If we were to go by the numbers that they have in China, it would seem that they have things under control. They have been trying to reboot their economy. They've used some very extreme measures to control it since January 23rd. They at one point essentially were putting 750 million people under stay-at-home orders. And it's really impressive that they were able to turn that outbreak around in the country as they've documented it, at least. Prior to that point, there was a dogma that was sort of floating around, I would argue, in epidemiological circles that you really couldn't bend a curve of an outbreak of a respiratory virus, a novel respiratory virus, to the extent that the Chinese were able to. And so what they did show was that is something that you can do, and that if you impose control measures, you can really restrict and throttle a respiratory virus that has high transmission potential. And further, they even showed that, you can use travel restrictions to aid that, which was sort of flew in the face of dogma as well. And the way they made it work was that they were pretty airtight. They really were able to really restrict it well. And that's, partly a function of the regime that's in place there and their ability to control people's movements. I think it's more interesting, actually, to look at what's happened in South Korea. There, we have a relatively open society. It's Western, it's democratic, it's densely populated. And they were really able to take an outbreak that blossomed unexpectedly on them and flatten and then crush it down and keep it at very low levels while maintaining some semblance of an economy. And that, to me, is the model that other countries should be trying to emulate.
What is it that they did?
Yeah, well, what they did, as I understand it, is they did close their schools, and there was widespread adoption and use of face masks, which were generally practiced and culturally accepted within Korea. And the biggest thing that they did is that they tested and they contact traced. And they did this very effectively, and they had the political and public will to implement it. And the reason appears to be because they experienced MERS within the last decade. And following that, 5 years ago, they put a law on the books in South Korea, as I understand, that allows them to go into people's credit cards and into their phone GPS and into their car GPS to figure out where they've been and what commerce they frequented, what stores, what restaurants, so that they could use that in support of contact tracing. And so they've tested abundantly. The number of tests they've delivered relative to the number of infections they documented, it's 60 to 1, 60 to 1. In the US, we're under 6-1 in terms of tests given to infections caught, which means that the Koreans are investing a lot more in testing in negatives and testing out in the community. And they're willing to get all those negatives so that they can find the positives. And then they're willing to go into the people's records and find out where they've been and who they've been in contact with and quarantine those contacts. And that quarantine measure is really vital for this disease because it's associated with both pre-symptomatic shedding and a very large portion of people who are undocumented and probably mild or asymptomatic for the duration of their infection.
My understanding is that the quarantine is facilitated by the government as well. They tell you, rather than just saying, go home, they give you appropriate materials and they check up on you and they really help you out and keep track of you. And I think, as you said, I think there's a sort of a cohesion, both politically and culturally, and a will to take this on in the public people, it's not universal, put it that way.
Well, and that has to do, I think, again, with the immediacy of the experience with MERS. Mm-hmm. I think that really primed their society to be ready for it. And if this had happened before MERS, they might not have reacted as well as they have. Mm-hmm. And they did some other things that were really great. I mean, because of that, they got together when this came out, and the government sat down with their public health agencies and their private companies and said, we need to develop test kits for this right away. And they did it where they assigned everybody go out and do it, as opposed to what happened in the United States, where it coalesced into a single test run through CDC labs that had some flaws and also was limited in who could be testing. They had a very different strategy that was much more aggressive and proactive right out of the gate in Korea. And again, I think this was really informed by their recent experience with MERS.
So when the incidence of infections in any given location bends over and goes down to some sort of baseline, what's your sense of the status of the environment in the virus in that environment at that time? I mean, I don't know if you can titer the virus geographically, right? Mm-hmm. But it's not gone, is it?
No, it's not eliminated. I think expecting to eliminate it is not a sensible end game.
Right.
Even in China, the idea that they would eliminate that virus there, I think it's not plausible. And there's no way, obviously, that they could go back to the level of commerce that they had before the pandemic without having it reintroduced. So it's got to be percolating within society in pockets and clusters. And the reason it's really supported is because there are enough undocumented infections. As a matter of fact, the majority of infections are undocumented, that this allows the virus to go through these long chains of transmission where nobody knows that this is actually going on in the community. Well, even a place like South Korea, this is ongoing. I mean, they're still getting tens of cases every day. And in spite of aggressive contact tracing and testing, they can't capture all of it. But clearly, they're eliminated any burdens, or most of the burden, I should say, on the healthcare systems. They're not overwhelmed. They don't have their ICUs overrun. They're not having to build up these crisis systems of emergency care response that are then pushing out routine services. And they have it at a level that's manageable where, people are still going to stores and going to work and going out and doing a lot of the normal commerce, albeit in masks and with certain social distancing practices in place.
So does that mean that the ultimate fate of this is to either through natural infection or vaccination, should that happen, to establish some kind of herd immunity? Well,
there are two other issues that really have to be contended with if you're going to look at it that way. The first one, which is a little more minor, is that the other get out of jail free pass would be an amazing therapeutic or set of therapeutics that effectively reduce the fatality rate, the duration in hospital, critical care need episodes, so that we had some real security that most people, even if they were infected with this, could be brought back around and saved, and all sort of illness diminished from that. So if there is some amazing medical countermeasure that would come on, that would be a real game changer. The other issue is there going to be herd immunity? And that's the thing that we don't know. And that's really going to depend on the level of immunity or protection conferred by one exposure. Are we one and done? Or are we going to be subject to repeat infections from this virus, either because of some form of waning immunity in the host or immune escape of the virus? And if so, what are the timescales at which that is going to happen? How often are people going to be subject to repeat infections from this novel coronavirus? And if they are, will they be experiencing milder symptoms the second time around? Symptoms that are just as severe, or symptoms that are worse? In truth, we really don't know the answers to any of these questions. Certainly, some of us may think some of them are more probable than others, but we don't know. What we do know is that if we look at the related coronaviruses, and there are 6 other coronaviruses that have infected humans of which we are aware, 2 of them were those pandemic emergences that took place in the last 20 years. One was SARS and one was MERS. Those were very short-lived and they were circumscribed. They didn't have the transmission properties that allowed them to get around. They didn't have this silent stealth transmission that happened readily in the community to allow them to spread globally. So they were able to be constrained and ultimately snuffed out. If we look at SARS-1, which is the most closely related virus, people who were infected with it and survived, they were found to have antibodies, presumably protective antibodies that were cross-reactive, 2 years post their infection. At 5 years, however, they didn't have those antibodies, though they did still have memory T cells and other indicators that might have conferred some protection. On the other end of the spectrum, there are 4 endemic coronaviruses. They go by, OC43, NL63, HKU1, and 229E are what they're called. These circulate all the time. They give everybody the common cold. 90% of the population is found to have antibodies against them, yet people are repeatedly infected with them. We ourselves conducted a study over the last few years. It went from 2016 to 2018. It was called the Virome of Manhattan. It was a project in which we were proactively sampling for respiratory viruses in New York City. In one of the arms of this, we established a cohort of people in which we asked them, after they were consented and gave us their medical history, to provide us a daily record of their symptoms with respect to 9 cold and flu symptoms, things like runny nose, sore throat, cough, etc. They would enter it on their phone. They'll go into our electronic database that we maintain. And they would do this on a daily basis. And they'd also tell us if they had taken medicine or stayed home from work or school or gone to see a doctor because of the symptoms that they were experiencing specifically.
This is for how long a period of time?
We did this for 19 months.
And how many people?
We had 214 people ultimately enrolled in it. So it was over 2 cold and flu seasons that we had this.
Wow, that's quite a bit of cooperation from this cohort.
It is good, but not everybody did it for the whole time. So we have people coming in and out. We have different length records for the people, but we did capture a very rich data set. And the last thing that we did, in addition to getting these symptoms, is that we swabbed everybody once a week, regardless of how they felt. And so what we were able to see then is a time series of symptoms that we could compare to respiratory viral shedding. And among the things that we saw were some interesting features generally, one of which is that, the definition asymptomatic is very squirrely. It's really hard to pin down. And, that should seem kind of odd. And some people sort of, raise their eyebrows and go, well, you're either asymptomatic, you don't have symptoms. That's what the word means. But the reality was that there were people in this cohort who reported symptoms every day. Regardless of what was going on. Maybe they had chronic rhinitis, maybe they had fibromyalgia, maybe they're just hypochondriacs, I don't know. And then you had other people who never reported symptoms no matter what they got. So there's a definition of asymptomatic is really weird. But what we did see within this is that even regardless of what you want to call asymptomatic or mildly symptomatic, the majority of infections for everything, that includes flu and human metapneumovirus, which are much more virulent, all the way down to coronavirus, the majority of them were in this asymptomatic or mildly symptomatic state. The majority of them, people did not stay home from work or school even for one day during the episode. And for the vast majority of them, people didn't seek clinical care. So even for flu, less than 1 in 4 people would seek clinical care when they had influenza. And it was down to 1 in 25 for the endemic coronaviruses. But getting back to sort of where I was going with this, the real issue was that for those endemic coronaviruses, we captured 137 infection episodes during this survey of the endemic coronaviruses. And that is 1 or more weeks of continuous shedding of the virus, of the same type of virus, OC43 or HKU1, et cetera. We did allow a 1-week gap in case there were false negatives or periods of low shedding, but we would define those as infection episodes. And we had 12 individuals who experienced multiple infections with the same coronavirus type. 11 of them were beta coronaviruses, which is the same genus as SARS-CoV-2. That is that OC43 and HKU1 are the beta coronaviruses that are endemic and cause relatively mild symptomology. And we had 11 people who experienced repeat infections as we've documented them. They came in 2 clusters. Some people experienced it 4 to 8 weeks after their previous episode had ended, which may mean that it was just some sort of low shedding or recrudescence that appeared. Maybe we are trying to investigate that because we're actually sequencing. We just sequenced those samples to see if it indeed is a variant or if it is the exact same genotype in the virus. But then we had another cluster that experienced it 8 to 11 months later, which we would not think of as recrudescence in any way. So what we're seeing is evidence of rapidly waning immunity or immune escape, something going on that allows people to experience repeat infections, and it may even be in the presence of antibodies that they have. This is all suggestive, but obviously these endemic coronaviruses are not SARS-CoV-2, so we still don't know, but it provides a piece of evidence that is indicative of something that we need to take seriously and really think about whether or not people, when infected, are going to be one and done with it, or whether they are going to be subject to repeat infections, and this virus is going to settle into a pattern of endemicity where people every couple years or maybe every year are being reinfected with it in the absence of a vaccine. And then the question, of course, is, well, how severe are those repeat infections? And of course, for the vaccine, can we make a universal vaccine, or do we have to continually provide yearly vaccines of some nature as we do for seasonal influenza?
Of course, if these reinfections are mild, as they are for the endemic coronas, then you wouldn't even need a vaccine, right?
Absolutely. And so that's one of the big questions. So if we have repeat infection and it proves that, once you've had this and you've gone through this all, the vast majority of infections are mild, then we really do effectively have a herd immunity that we don't need to worry about too much, because clearly young children, when they get this, which is what will happen as new people are born and experience this coronavirus, if it continues to circulate, will most likely have mild reactions to it on first infection.
Yeah, Stan Perlman had suggested that as much, because these endemic coronas, as you know, originated in rodent or bat sources many hundreds of years ago. And so, we don't have any records, but maybe at that point they caused an epidemic that was quite serious, and then, went into this cycle of endemicity where they became mild.
Absolutely. I mean, and that would be, a best case scenario. Maybe not the best case, but that would be a welcome outcome, certainly.
So I have a couple of more questions about this study, a fascinating study that you just elaborated on. Was there any serology, in particular baseline serology, going into this? Or do you have to, I guess you could assume basically that 90% of your cohort was coronavirus positive anyway?
We could certainly assume that. We do have samples which we have yet to process.
Okay.
That we want to look at that specifically.
And if I understood it correctly, you said that of the whole cohort of over 200 people, there were something like 130 who came down with documented coronavirus infections, and of those, on the order of it was 11 or 13 individuals experiencing reinfection. So it's about, did I get those numbers right? Is that about 10% of the coronavirus infections or 10% of the individuals who had coronavirus infections had reinfections, right?
Yeah, that's about right.
So, do you have any sense of whether there is a subpopulation that is susceptible to reinfection, or whether this is just a stochastic thing, and over that period of time, you happen to capture 10% who got reinfected?
I think it's a little bit too small of a sample to actually say one way or another in that respect. What we could look at is, and we did look at, is we did some survival analysis, and it seemed to indicate that the probability of having a second infection with the exact same coronavirus was just as likely as being infected with it once. We found the exact same timescales on it.
All right.
You know?
And so I guess if you either assume that they're all seropositive to start with or don't have much data, you can't really address whether the reinfections are milder than the initial infections, because you don't really know what the initial infection was. Is that correct?
We can only compare the two, but we don't know what the initial infection. What we saw was that there was no difference in severity.
None of these were any of the coronavirus infections? Were any of them severe or involve hospitalization or anything?
No, none of them did. None of them were that severe, but the symptomology didn't show any trends of more or less. Now, one of the things that we're going to have to look at with the sequencing, of course, is are these really radically different variants? If these have been circulating for so long, you may have many, many variants of OC43 subtypes, if you will, floating around is what is really allowing to get these infections, where maybe the antibodies that we develop early on are just no longer really protective against these varieties that come in, and we don't, for whatever reason, really get boosted or develop new antibodies that are effective against them. Or, I don't even know. I mean, we're going to have to just see what's going on.
Nobody's done that, right, for these seasonals?
No. I mean, there could be an abundance of different strains of these coronaviruses circulating, which may be why we're seeing these repeat infections. And it may not be as applicable for something like SARS-CoV-2, which has not had the time to diversify.
But certainly the low antibody titers are playing some role, right?
I would think so, yeah. But something we have to check further, though.
So if we're headed towards a situation where ultimately this is going to be managed, if you like, by the establishment of herd immunity, I've heard a number of different numbers as to what percentage of the population needs to have some immunity in order for herd immunity to kick in. Can you give me your assessment of what level of immunity we need on a population scale in order to...
there's a calculation that I never can remember. It's like 1 minus 1 over R naught plus.
Yeah, it's it.
Something like that. I can never remember exactly what it is. But I mean, it depends on that estimate of R naught. And, the estimates of R naught they were first coalescing to being around, 2.2 to 2.5. But now we're seeing them really diversify, and they're ranging from like 1.7 up to 5, maybe even a little higher than 5.5, something like that. It depends on that, and I think it's going to be highly sensitive to population. We have to recognize that this virus feeds off of opportunities to transmit. It feeds off of person-to-person contact, and I say that in an abstract way because people don't need to be in the same place at the same time to actually transmit this virus. You could go into a grocery store right now, not wearing a mask, let's just say, to make it a little more dramatic, and you're pre-symptomatically shedding, and you fill the air and you can cover the surface with virus, and somebody could come in a half hour later and pick it up. And that's all possible. Those are all possible routes. You don't have to actually overlap in space and time. However, if we were to look at where the virus has exploded, it's been in major urban environments predominantly. We see this. And there's two reasons why this is sensible. Firstly, that's where the major airports are. So there's a greater likelihood that you're going to have introduction of the virus into major urban settings. But the population density there is going to support transmission at a higher rate than in some rural place. A rural county in eastern Montana does not have the population density that Manhattan does. And that is going to change the transmission dynamics, because when I live in Manhattan, and when I go around, on a normal day, if I'm going to work on the subway, which I do, and I go to work and I stop off at stores, I am crossing paths with hundreds, if not thousands of people in a day. And that is something that you don't get in more spread out settings. So there will be variability in context in terms of what herd immunity needs to be. But, if it ranges between 2 and 4, you're going to need 80 to 95% herd immunity to get this thing really under wraps. Maybe you can get away with 75, 70% if it's a very low R naught. But again, I guess I'm just stressing that it will be variable and it's going to depend on the setting. And what you're going to need in a dense environment like New York City should differ from a more sparsely populated area.
I guess I'm trying to understand the reason for the current decline in daily infections. So maybe you could explain that, because it's clearly not 70% herd population immunity yet. My thought is it has to do with sheltering, but some have written that it has nothing to do with sheltering because there are countries that don't shelter and it's declining as well. Maybe you could address that for us.
Oh, I think it definitely has to do with sheltering and social distancing. And I think there are a variety of ways to short circuit the transmission pathways that this virus exploits, which we don't really fundamentally understand. I mean, if I can digress for just one moment, when this virus came out, there were people who were getting out and saying, well, it's transmitted by droplets. It's droplets. It's all droplets. It's people spraying each other in the face. And the answer is we don't know that. We don't know that for any respiratory virus. We don't know how they can be. We know how they can be transmitted, We just don't know how they are. And we don't know that for this one either. Certainly when people cough and when they speak and when they even breathe, they're expelling lots of respiratory droplets all the time. And if you are infected with this virus and you're shedding it, presumably some of them will be contain viral particles, right? Now, it may be more that the big goopy stuff that comes up with a cough is going to have more of that because you're working it up out of your system and there's all this other crap associated with it. And the little tiny ones that come out when you breathe may not be as likely to have virus, but we don't know that. But those virus droplets, when they come out, they have basically 3 routes that we're really concerned with right now for transmission. One is that you might spray somebody in the face, you cough, you speak, you breathe, you could hit them directly in the face, and they rub their eyes, they pick their nose, they eat a cheeseburger, or move things around, touch their mouth, etc. They're going to potentially get the virus from that. And the second one is that it can land on surfaces, of course, and that's fomites, and that's the indirect route, and that's why they tell you to wash your hands, because they don't want you to transfer it to your hands and then do those same things of rubbing your eyes, picking your nose, and eating a cheeseburger. The last one is that some of the droplets may be very small or evaporate down, and they can become aerosolized, and they can float around the room, and then you can inhale them. And that aerosol transmission may be very effective because it may take the virus deep into your lungs, into the alveoli. And some people have speculated that where you get the infection, whether the virus gets into your system in the upper or lower respiratory tract, may be an indicator of how severe the infection is. We don't know, we really don't know. So we have all those different modes that are possible. And within that, there are lots of ways that you could potentially disrupt the transmission of the virus. Certainly, the fewer people that you hang around, the fewer opportunities there are for people to actually transmit it to you. Then there is this idea, well, if you are out and about and you socially distance and you keep 6 feet apart from everyone, are you providing sufficient space between yourself and other individuals? And does that help? Well, maybe. We don't fully know, but maybe. And then there's face masks. If you go out and even if you congregate, if everybody's wearing a face mask, is that going to be helpful? Well, there's some evidence that certainly can be helpful. And certainly if you yourself are contagious, you would expect that prevents you from effectively or as effectively spreading the virus to other people. So what I think is going on is that the various interventions that we put in place, the social distancing, the limiting of mass gatherings, the closing of schools, the encouragement of telecommuting, the closing of businesses that are non-essential, the request to social distance, the encouragement of wearing face masks, all of them may be effective at one way or another at reducing opportunities for transmission and essentially reducing the effective reproductive number for the virus. What's very difficult to know is how to disentangle it and say, well, which one of these has been most important? Without knowing what the mode of transmission is, without being able to observe it, we can't answer that question. It would be great if we could, because then we could say, look, we need to really wear masks, limit the number of people in stores, do contact tracing. And you can see I'm painting the same pictures what the South Koreans have done because they've been so effective. But some combination of these measures is clearly been effective at flattening the curve, because I don't see any reliable evidence that suggests that we're anywhere near herd immunity at this point.
So are there countries who have not done any social distancing at all?
There are some that have been in denial. The president of Belarus was, as making himself, Lukashenko is making himself quite notorious for playing hockey and denying it, but they have rising numbers of cases there. Mm-hmm. Sweden is the really curious example. They have not done too much. They limited or banned gatherings of 50 or more people. And then they mostly just, for the first part, encouraged their population to telecommute if they could. But they don't have masks. The restaurants and bars and businesses are all open. People still use the public transportation systems there. I believe they've done some things with their school system more recently. I don't quite remember, so I'm not going to get that right one way or another. But they're sort of, what they've done in doing this is they set up a natural experiment where they could be compared to Norway and Denmark, the other Scandinavian countries, which have been a little bit more aggressive about it. And we do see differences. We'll have to keep an eye on what's going on there. Sweden's population is roughly double that of Norway, I believe. But Sweden has 10 times as many fatalities due to COVID-19 at this point. They have about the same number, or maybe it's just double, which is in proportion to their population of documented cases. But that, again, would indicate that they're not testing as aggressively. Yeah.
So should we be doing more PCR diagnostics and contact tracing in the U.S. at this point?
I think we absolutely have to be. I think that would be the thing to do. Given the success that the South Koreans have had in utilizing that, and mind you, obviously what they do is a law that they have on their books that allows them to go into people's credit cards and phone records, et cetera, which is a privacy invasion, an invasion of civil liberties that many in this country will object to. And the Koreans were fortunate enough that their society was primed for this with their MERS experience, and we did not have that. I say fortunate. Maybe I shouldn't use that word. But I do think that if we want to throttle this disease with our available non-pharmaceutical interventions as we have right now, we want to minimize its progression and allow ourselves to go back to work, we have to be going out into communities and actively trying to identify infections. And the most important thing is not just to get those initial infections, but to do that contact tracing. Because if you then quarantine the people who've been in contact with an infectious person, you're having the possibility of nipping in the bud any sort of pre-symptomatic or asymptomatic shedding and transmission before it takes place. And that, I think, is the critical step that really allows you to squeeze this virus down and limit it. So you go out there, you find people who've been in contact with this person who's now come up positive, and there's a big lag, by the way. Got to remember that, somebody acquires the infection, they go through a 3 to 5 day latent period. Then they'll have a 2 to 3 day period of pre-symptomatic shedding if they become symptomatic. Then their symptoms onset, and there's going to be a couple days of those symptoms worsening and developing. Who knows, maybe 2, maybe 7 days before they actually seek clinical care. And then they may be tested. And it used to be anywhere from 1 to 7 days, the turnaround of the test. Now it's gotten shorter. But even without that testing lag, you already have this built-in 7 to 14 day lag. It's quite large, which means that everything that you see today in terms of confirmed cases is an indication of what level of transmission was taking place 1 to 2 weeks ago. And it's really critical that if you find cases today, that you find the people they've been in contact with who are lagging behind them in if they are infected, who didn't get infected until after that person's latent period at the earliest, right? And so then you can catch those people earlier in their cycle, and you can get them out of circulation for a time. And you can test them, and you can find out if they're infected. And if they're positive, you can then trace their contacts as well. It's a very arduous process, but if it is implemented, if we do build an army of contact tracers who are doing this with the authority to have people stay at home, and as Rich pointed out, the materials to help them with their quarantine, we might be able to really throttle this disease.
But by throttle, if I want to coming back to this, we're not talking about getting rid of it necessarily. Right. We're talking about managing it through surveillance and containment to the point where the healthcare system can give the people who do get sick the best care they can get. Am I thinking about that correctly?
You're spot on. You're absolutely spot on. I mean, the reason why we want to quash the curve, say in New York or New Orleans or Detroit, is that we have two aims. We want to be able to alleviate the burden on the healthcare systems. We want to be able to get out of this state of crisis care that we've been in, for instance, in New York City, where we've had to, surge capacity of ventilators and ICU beds and even hospital beds. We want to pull that back so that we can elevate the standard of care back to its normal levels so that people who need a ventilator or need an ICU bed get it when they need it, not 3 days later and 12 hours before they are going to die. So we want to return to a normal standard of care. And we want to be able to deliver all the other healthcare services that we want to routinely deliver. You have this kind of surge that took place where Elmhurst is overrun and they're putting up these pop-up hospitals in Central Park and they're using the Javits Center. And it not only compromises the care that you can deliver to people with COVID-19, it sidelines everything else. Childbirths, routine childhood vaccinations, dialysis, chemotherapy, car accidents, everything gets sidelined and you can't get that. And so there are all these associated and attendant healthcare consequences of not being able to deliver services for people in need the way you normally do. So by pulling that back and by quashing it down and by controlling it, you're going to provide an environment where the healthcare system is ready and capable of dealing with the demand, which is greatly reduced under this throttle scenario, if you will. And the other thing,
I can see where this would not be the measures at any given time would not be one size fits all. This is where the surveillance comes in, because some communities, some areas, as you've already pointed out, are going to have different issues than others. So if there's a sort of a drill for dealing with this, it can be applied appropriately at different places at different times, if the surveillance is right.
Absolutely. And you see, the other thing that the surveillance does, by being active about it, it will give you some insight into any cluster or outbreak or return to exponential growth that takes place in a given community earlier than if you're just waiting for patients to come see you. So you can get some indicators of that allow you to adjust exactly what you're talking about, that adaptive response. So, even in places like New York and Los Angeles may have very different set points because LA is such a spread out car culture, whereas New York is such a dense, particularly Manhattan environment where everybody's using public transport and the population doubles during an average workday, more than doubles. And then you go from LA to some sort of smaller town or to a very rural environment, then you have different needs in terms of how much control has to be implemented. The thing that's challenging here is that it would be, we need some direction to do this. Doing this piecemeal without unified communication across all the different states and sub-jurisdictions that exist is not an effective way of doing this. We have to be sharing practices, finding out what works in certain communities and hasn't worked in others, and using that to intelligently adjust how we're going about the management of this disease and the return to economy as best as possible.
Well, these things you're suggesting, these, diagnosis and contact tracing, this is not going to be done, right, at a coordinated level, as you say.
I don't see it happening. I don't, well, at least not in the near term. It really requires coordination at the federal level and investment in funds from the federal government, which is the only entity that can print money. dumping it on the states is, look, it's an abdication of responsibility and policy. And the states will try to do what they can, but that's going to make it more challenging than if we had a coordinated effort. Even with that, if it were coordinated, spinning it up it could take some time. We could do it, and it could have been done faster. And actually, I take that back. I think it could have been done if the sense of urgency and if the marshaling of resources had been made to train 100 or 200,000 people in epidemiological contact tracing.
Mm-hmm.
We have an epidemiological intelligence service, the EIS, and we have public health services systems that are capable of training people to do that. It's a question of figuring out how you're going to train them, how you're going to fund them, how you're going to resource them, what you're going to let them do, what authority you're going to give them, and to assist people and compel people to quarantine if they need to, for instance.
So instead of PCR testing and doing what you're suggesting, instead it seems that states at least are getting interested in antibody testing. So maybe we could talk a little bit about that and your thoughts on what the value there is.
Well, there are a couple issues with it. Firstly, there's a notion that we could have these antibody tests rather than an antigen test, as you point out, that allows you to identify people who've been infected. And if indeed people were one and done with this, or if, let's just start with one and done, which means that you're a dead end and you're not going to be part of a future transmission cycle, and you're not going to be able to get it a second time and give it to somebody else, which is very important. Even if you were to get a mild infection the second time, there's still concern that you're going to give it to somebody who has yet to have it in the current circumstance. But if people were one and done, the idea being that you could show that you have good antibody titer to it, therefore you should be allowed back to work and allowed to do what you want because you are not a harm to either yourself or anyone else. We don't fully know that because we don't know about this repeat infection thing. And if there is repeat infection, then you are potentially harmful to others. And if the repeat infection is potentially severe, you may be harmful to yourself. But the other thing that we want to use them for is to try to get a sense of how much penetration into the community has there been from this virus. What is the level of herd immunity potentially out there? How many people have been infected thus far? What's the attack rate? And what is the true ascertainment rate, which is that what fraction of total infections have been documented? Now, the initial estimates of it was something that my group did for China was 1 in 7, and for the United States was 1 in 12. Is what we estimated.
That's the ascertainment rate.
That's the ascertainment rate.
Okay.
So that means that for every 12 infections, 1 was documented, was a confirmed case, and 11 were undocumented and out there. So we have that initial type of estimate that's done from a model inference system, but there's been a desire to try to validate that or reconcile that using serological assays, and that's very important. The things that have been coming out now of late have been some of these seroprevalence studies. We saw one in Santa Clara County last week. We also last week heard of a study that was done in New York State and New York City. The issues associated with them are that the kits that have been made may have specificity issues that make it problematic or highly biased in their estimates. Particular, and I'm going to pick a little bit on them, but just to show what it is, there was an estimate for the Santa Clara study that was done by some researchers out of Stanford, and they went and they tested for 3,300 people in Santa Clara County for antibodies. They know what the number of cases had been to date, and what they found was a certain number of these 3,000 people, roughly, tested positive. And they then adjusted for the demographics, and they said that 2.81% of the county had thus far been infected, which is not a high number and is nowhere near approaching herd immunity. But given the number of cases that were there, they said that implied that there was an ascertainment rate that wasn't 14% as we found for China or 8% as we found for the US, but between 1.2 and 2%. So 1 in 85 to 1 in 50, much lower. All right, which if it were true would be good because it would mean there's much greater penetration of the virus into the population. If you had a 1 in 100 ascertainment rate right now, we've just crossed the 1 million confirmed case line. That means that there are 100 million infections out there, which means that we're approaching almost a third of the population in the US has already experienced this infection, which means that we're a lot further along to getting to herd immunity than we had thought. Whereas if it's 1 in 10, then it's only 10 million people, and it's really a drop in the bucket, right? But this 1 in 50 thing is problematic because the tests for these serotests, because they have problems with their specificity, where the manufacturers seem to claim one thing, but then when they're run in actuality, they drop some percentage points. They go from 99% specific to 95% or even 90% specific. And those are big changes because if you think about it, if in truth, 1% of the population is infected and you test 3,000 people and you have 100% sensitivity, that means you're going to get all the people who are positive as positive. That means you're going to get 30 people positive there. Then if the remaining nearly 3,000 people are truly negative and 5% of them are falsely called positive, that's 150 people who are going to be identified falsely as positive. That's 5 times the number of the true positives. So you've now greatly overestimated the actual seroprevalence for this virus because of this flaw in the kit. Now, if you know exactly what the specificity is reliably, you could adjust for it. But the problem is we don't know what that is. We're told it's 99, 98%. And then the CDC will do a bunch of tests or another group a bunch of tests and say, no, it's more like 90%, which means that you've enormously overestimated the number of actual infections that have taken place in the community, which leads to this enormous drop in the ascertainment rate so that it becomes like 2% or 1%. I don't find them credible as of yet because it doesn't seem consistent with multiple other lines of evidence, which suggests it's more like in the magnitude of 1 in 10, not 1 in 100.
So there's been some reports from Governor Cuomo that the New York rate is about 20% based on antibody tests. You think those are equally suspect?
I think we have to view them cautiously. I like them better personally, I hate to say, because they align with our own estimates. So I'm biased. I will admit that bias. But we need a lot more of this testing. And we need to have a better handle on what those specificity rates really are and the sensitivities for the tests that are being used.
So given all these uncertainties, do you personally have, any even approaching an estimate of either the infection fatality rate or the degree of penetrance in the population at this point? I realize it's going to be geographically variable, but what's your sense at this point? Or is it just too uncertain to even make a guess? Well,
there is uncertainty, and there's uncertainty in everything here. I mean, essentially, we've had this alien thing to us plunked down in our midst, and we're rapidly, desperately trying to figure out as much as we can about it, right? However, I'm not going to rely on the seroassays. I'm going to rely on my own work, which other people might be suspect of, which is model inference work. And we seem to be indicating that it's about 8 to 10% the ascertainment rate. And, if you do a back of the envelope calculation and you were to say that in the United States, we have 340 million people, and in a worst case scenario, this runs through 80% of the population, right? So let's just say that's roughly 250 million people. That's a little low, but we'll call it 250 million people get infected. And then if you say of those 250 million, roughly 1 in 12 of them will be documented. So now we're at, what is 1 in 12 of 250 million? 1 in 12, it's like 20 million people, right? Roughly. 20 million people then are going to be documented confirmed cases. And then you could work off the case fatality rate, which here in the US, the last I looked at, and look, what is it? It's about 5%. That means 1 million people die in your worst case scenario. And that's a lot of people to die if you don't constrain this thing. And what does that factor to? That takes that 5% case fatality rate and it divides it by about 12, right? So it's about a 0.4% infection fatality rate.
Okay.
And I've seen other estimates that say 0.4 to 0.6 seems about reasonable. right?
But given our previous conversation, I'm going back to this. It seems to me that if you can manage this in a fashion where the everybody gets optimum health care, that given those numbers, the 1 million deaths is going to be the same no matter what. It's just a matter of over how long a period of time that's going to happen. That
is one of the worst case scenarios. That is the thing that can make people sort of suffer a real, cognitive dissonance and despair, because you're sort of between a rock and a hard place. Do you slowly let it meet out, or do you let it rush over you all at once and try to get back to an economy? I think a normal economy. I think that we have to find a median. We have to find something along the lines of, I keep saying it, the South Koreans. They have maintained a semblance of an economy. It is not what they were before the pandemic, but it is not like what we are experiencing right now. And it allows the vast majority of their population to work and to maintain commerce and to put food on the table and pay the rent. And that's something that's really vital that we have to be able to do. So we have to find a balance that allows us to do that. And again, doesn't overburden the healthcare system so people aren't dying unnecessarily.
Right.
So despite these considerations, many states are lifting stay-at-home restrictions and so forth. And the New York governor the other day has a plan for slowly reopening the state. And he said that, if hospitalizations decline for 14 days in a row, then they'll start slowly going back to work. What do you think? That's not a good idea?
Well, I honestly think that we do have to have some return to economy. Without right now, there are people who are not getting unemployment benefits. They're not able to access it. You hear lots of stories about this. We're putting people in circumstances where they can't feed themselves. And that is a hardship. We have to try to find a balance here. However, it may be a little early. You may really want to crush this curve down even further, really remove even more of the burden from the hospital systems than a 14-day decline. Mm-hmm. I mean, I think ideally you want to really get the effective reproductive number well below 1, so that when you do open up the economy some, you have some wiggle room, so that if it goes from 0.3 to 0.8, you're still good. You haven't crossed 1. You're not in a period of growth, and you're probably going to be able to manage things better. I think giving yourself that leeway before you go into it, both so that you don't cross 1 and so that the hospitals are ready and open for business in a functional way, those are the two critical pieces. So I don't know if 14 days is the right magical number for that. Obviously, in a perfect world, we'd have lots of testing and contact tracing. But I don't see that happening in the near term. Hopefully,
so
we can build up.
You're making me think. You're talking about being able to, at any point in time, report a reproductive rate in a given locale, which, of course, is going to be a function of lots of different things, including behavior. Yeah. So, does that come out of the surveillance, so that if the surveillance is good enough, then at any particular point in time, you can say, well, right now at this point in time, the reproductive rate is such and such?
We try to estimate it. I mean, it's a challenging problem because there are differences in rates of testing that happen all the time. And if you were to suddenly have people going out in the community and testing more aggressively, that would disrupt the numbers and the way they're reported. But that's something that we try to do all the time. We do it for a lot of the counties in the U.S. I can't say we do it on a county by county basis for every single one of them, but for the places where there's lots of activity, we estimate that R0 as it changes through time on a daily basis. Now, whether those estimates are accurate is something that, we can always question, and it's always going to have to do with some of the assumptions that go into the system that we're using to make those estimations. But that's something along the lines of what you'd want. You'd want multiple groups making those estimates so that you have a diversity or a range of estimates to work from to see what kind of consensus or disagreement there is amongst them.
the data that goes into those estimates, is that just cases or
we use cases
rate as well?
We use cases, we use deaths, and we put it into what's called a model inference system, where we have a mathematical model that describes transmission dynamics throughout the country at a county scale. And we use that data in combination with what's called a Bayesian inference algorithm to estimate that reproductive number and see how it drops over time. Yeah.
So I have one more question. Can you look in your crystal ball and tell us what's the next month or two, what's going to happen with the virus spread and cases and so forth?
What I think we're going to see is the consequences of our public and political appetite to reopen the economy. And what we're going to see is some successes, and we're going to see some clusters of outbreaks probably as well. I think the crystal ball thing is really challenging. So, for instance, in Georgia, on last Friday, they reopened, nail salons and bowling alleys. And then on Monday, yesterday, they opened restaurants and movie theaters. And that's all well and good. But the same way it's hard to get people to comply with the shelter in place and the masking wearing and the social distancing, it's not like people are suddenly going to frequent these establishments as they used to. A lot of the establishments and restaurants in Georgia, for instance, were saying, we're not going to open. We think it's too early. And then for the ones that opened, you have to wonder, well, what fraction of their clientele is going to be willing to actually go there? And if you ask people, and I had a lot of reporters ask me that over the last week, I would just ask them, I said, would you go to a restaurant now? And every single one of them said, no, So I think there's going to be a lot of wait and see attitudes. We're not going to really see a flourishing of the economy in Georgia or Texas when they reopen them. We're going to see some baby steps. And people are going to wait and try to see. And then if after a week or two, which isn't long enough, they get a sense that things are okay, then some complacency or willingness to go back to use frequent those establishments will happen. And you'll see more people using it and more people. And that could snowball. And that, because of the lags in the system and the exponential growth, when you do have an outbreak, could ultimately be bad. But we will see. We'll have to see how it plays out. I also think that, if Georgia's experiment goes well, other states are going to be eager to jump on it. And if it backfires, they're going to be like, no, we can't do this. And they're going to reevaluate when they actually reopen and how they do it. So I think there's going to be a lot of learning from the experiments, the natural experiments as they are, that are going on between different states.
So ideally, we would have accompanying these reopenings, extensive testing and case contact tracing, and that would help support if there's a new outbreak, to quarantine people and so forth. That might help, right?
Yeah, it would tell you whether or not you have an outbreak earlier. It would allow you to snuff it out potentially, and it would facilitate going back to work, so that you can manage those cluster emergences of
instead, in our society, we have a sort of you first, and then I'll watch the news. Yeah. We do, and but on the other hand, we also have a number of political leaders who are me first. So there we go. They're going to do it. Unfortunately, the general population is going to have to bear the consequences.
Well, maybe we can have you come back in a few weeks, Jeff, and we'll get an update and expand on what's been going on.
I'm going to ask Jeff whether there's anything that we haven't hit on that's really important for an episode like this.
I think we've touched on a lot of the topics. There's tons more that we can talk about, no doubt. But we've talked about a lot of the issues that I think are particularly relevant at this point. I'd be happy to come back on, Vincent. Absolutely.
That'd be great. Because, in this time, our listenership has really exploded. We've been releasing a couple of episodes a week. And so, people are going to love to hear what you have to say today. I can tell you that, because we haven't had an expert on since the beginning. So,
yeah. And a month from now, it may look quite different.
Absolutely. I mean, it's really hard to know what the future has in store with this.
Yep. Okay. All right. That is TWiV 607. You can find the show notes at microbe.tv/TWiV. Of course, you can listen on any podcast player on your phone or tablet. Please subscribe. You get every episode, and we know how many people are listening. You can send questions or comments to TWiV@microbe.tv. If you like what we do, consider supporting us. Microbe.tv/contribute. Our guest today from the Mailman School of Public Health at Columbia University, Jeff Shaman. Thanks so much for joining us.
Thanks for having me. My pleasure.
Rich Condit's an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure thing. And thank you very much, Jeff. This has been awesome. I really appreciate this. A lot of questions that I've had have been addressed here. Thanks.
My pleasure.
Rich, are they opening Texas sometime soon?
Well, that's the governor says that they're going to open up, I guess, this Friday, whatever that means. But, you know, I think that there's a lot of local variation in Texas. I don't read the paper as religiously as my wife does, so I'm going to have to go ask her. But, you know, Austin is, marches to the sound of its own drummer. And so I also don't know whether if the governor says you can open up the restaurants, whether Austin can say no, you can't. All right, I don't know how that plays out. So I'm a little uncertain, but I have heard that the governor wants to quote open up unquote. I don't know to what degree on Friday. Yeah.
So if they open up, Rich, are you going to a restaurant next week?
No. As a matter of fact, I take my advice from my daughter. Okay, my behavior is very much. I want her and her family to be comfortable about my health and their health as in relation to me. So I'm probably, given my proximity to them, I'm probably locked down even more than I would be under normal circumstances. So, I mean, I haven't been into a store in 5 weeks. Okay. We do our grocery shopping by picking up the groceries. And beyond that, I don't even go out of the neighborhood. You know, I walk around the neighborhood and I got plenty to do, and Zoom is terrific. So, you know, that's the way that works.
All right. I'm Vincent Racaniello. You can find me at virology.blog. I want to thank ASV and ASM for their support of TWiV and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.